With B12 deficiency, who do you normally see this in? What type of profile? And is there a different pattern of the neuropathy there compared to the alcoholic and diabetic?
Yeah, it sometimes overlaps. They can look similar in the beginning, okay, or at various stages, it can look very similar. One of the things that B12 deficiency does that, say a diabetic neuropathy wouldn't, is there can also be injury happening in the spinal cord itself. So patients can get signs of spinal cord problem. And a lot of times that's not discovered until you see a neurologist and someone puts that together. It's hard to know you have that. It can also cause cognitive problems. It can cause brain fog, trouble thinking, memory problems. So it's kind of more widespread than just my feet are tingling. Although it starts that way oftentimes, there's more to it potentially. And, the patients with B12 deficiency, that runs the gamut as well. So you can have someone who's just dietary reasons they don't get enough of it. Other patients, especially with the more severe deficiencies, maybe they have a GI problem. So they have inflammatory bowel disease and they can't absorb the B12, or say celiac disease or a stomach disorder. There's many reasons why someone might not be able to absorb the B12 and then they get a deficiency.
What kind of diets are tend to be more deficient in B12?
It's one where you are lacking either some protein source for B12. The thing that everyone knows is red meat, yeah, but it's in other meat too, and actually a lot of seafood too. Shellfish has a lot of B12. Clams and mussels and things like that actually are an excellent source of B12. So even if you're not a red meat person, you can still find B12 out there naturally in food.
Got it. So a vegan or a vegetarian might be more likely to be deficient.
A vegan, someone who's not eating any meat or any animal product, they're going to need a supplement.
Got it. And if people supplement, whether they need to do it because of their diet or because of one of these GI issues, do they tend to be able to go back to normal functioning and normal levels?
Generally, sometimes people need injection. So if you're not absorbing, then you need to have an injection that bypass the GI tract. And hopefully with treatment, a lot of times people's nerve problems or cognitive problems can be reversed and they can get back to a more normal situation.
Got it. So it's not necessarily permanent damage in the same way that diabetics or alcohol
Yeah,
can
it
be.
can. Yeah, it
It
could
can
be.
be still.
Yeah, in the most severe case or long-standing. But generally speaking, a lot of patients can get better.
Got it. And what this just came to my head, and you could tell me if it's dependent by patient. What are the levels of B12 that you like to see people at? Like what's
Yeah,
kind of your, because I see different ranges in different labs.
yes, there's some variability in the lab assay and lab assays, I should say, across the board. And there are situations where patients have a very convincing syndrome that fits with B12 deficiency. Let's say their actual number is 280 and the lab says the number is 250. It's technically normal, it's not red, but the patient has a very convincing syndrome, everything adds up. Well, that person probably has functionally a B12 deficiency, or they're deficient for what they need. And we can occasionally do additional testing, say testing of methylmalonic acid or homocysteine or these other markers, to kind of give additional evidence that there's some, dysmetabolism, to strengthen our argument that level needs to be higher. So I tend to start to get worried in the right patient, so someone with the right symptoms, when their level starts getting to 300. Okay, even if that's not red on the abnormal on the assay, that could still be abnormal for that person.
Got it. So you like to see it above 300, or at least that's when now you think someone's going to be more at risk of having the syndrome.
Right.
And everyone's different. These lab normal ranges are not, they don't apply for every single person. So you defer to symptoms when it gets closer to that point.
We have to make sure everything makes sense, things go together, the patient has the right symptoms and problems to fit the lab tests we're doing. Things don't add up, then you have to look for other things.
Got it. And are there any specific sensory or even balance or nerve findings that make you think B12? Or is it still kind of general and you're going through a list of things?
You can see balance problems as part of the spinal cord syndrome that happens. And that's oftentimes picked up on a physical exam. So when we're doing a neurologic exam, if I see a patient that sounds like a neuropathy, I go start examining them and they have signs of things that don't fit with peripheral nerve problem, might fit with spinal cord or brain problem. Now all of a sudden I start thinking, could this be B12 or something else that's affecting other parts of the body other than just nerve?
Got it. And do you ever see nerve issues when people have too much B?
No, not generally. So, we don't want the level to be sky high. It's better to be in a more normal range, but there isn't a specific nerve or neuromuscular disorder from too much.
What is the interplay between MMA, methylmalonic acid, and B12? Like, how are they related?
Methylmalonic acid is, just another one of these tests we can do, but it's involved in the metabolism for B12. And if someone is B12 deficient, it prevents the metabolic pathway from moving forward. And then methylmalonic acid will start to build up in the body and it's prevented from moving down its pathway. Then you can detect that. Okay, so it's a marker of that problem with metabolism.
So if someone's having that B12 syndrome, but let's say their B12 is borderline low, 280, 275, maybe you're not sure, you check the MMA, and if the MMA is high, that gives you more confidence that, okay, yeah, this is a B12 deficiency in this person.
Yeah, that's correct.